And some may also come in complaining of pain. So dysuria. So dysuria is also one of the signs and symptoms. All right, so any questions? So these are the storage or irritative symptoms, then the obstructive or avoiding symptoms. Okay. Let's move on to talk about the diagnosis. So for the diagnosis, basically before you do any diagnosis, the first thing you start with is the history. So you first take the history. And the history is very important because if a patient comes to you complaining of urinary frequency, urinary urgency, don't think about BPH straight away. Look at the person in front of you. If you have a 30-year-old female coming to you complaining of urinary frequency, dysuria, urinary urgency, I won't think about BPH because females do not have what? Prostate gland. Even though the symptoms that the patient gave me are lower urinary tract symptoms. But I wouldn't think about BPH because she's a female, 30-year-old. The first thing I'll think about is possible UTI because UTI can do all these signs and symptoms. If you have a 60-year-old coming to you complaining of these things, dysuria, intermittency, and all that, then you think more BPH because the person falls within the age bracket and is also a male. And the history is very important again because someone who is diabetic can tell you they are having urinary frequency. They wake up at 9, several times to go and urinate and all that. So don't just say it's BPH without doing your investigation because diabetes can't do that. So it's very important we take history. So history is the very first thing. And the history, you also be asking the clinical symptoms. So you want to find out, do you have urinary frequency? Do you have urinary urgency? Are you having pain during urination? When you're done urinating, do you still feel like there's some urine left? And do you have breaks in your urine? Is there any splits? So all these are relevant questions you want to find out in the history. Then the next thing is clinical examination. For the clinical examination, a common bedside test we do is what we call the DRE. And DRE stands for digital rectal examination. So you do a digital rectal examination. Basically, this is done by the physician. So the attending physician wears gloves. So first, the patient is positioned on the lateral side with the knee flexed towards the body. So they sleep on their side. They can be on the left side and they flex their knee towards the body. So once you flex your knee towards the body, the doctor inserts his gloved finger in the rectum. Remember during the anatomy, I said the prostate gland is anterior to the rectum. That means it's accessible. If you are able to go through the rectum, you are able to get to the prostate gland as well because it's just anterior to the rectum. So once the doctor inserts the finger, he is checking for certain key things. One is the size. So BPH, we are saying there is increase in the cell number that causes increase in size. So he wants to check the size of the prostate gland. He also wants to check the texture. So in terms of the texture, is it smooth? Is it rough? Because if you are thinking of BPH, usually there's an enlargement, so the size will increase. But in terms of the texture, it will be smooth. It wouldn't be rough. However, if the patient has prostate cancer, then it's likely to have rough edges. So you can have rough edges in prostate, but typically BPH is usually smooth. Then the doctor also checked for the presence of nodules. So he palpates the prostate gland to check for the presence of nodules. So these are the things the DRE will tell us. So how do we know the size?
Hello.
So the average. Hello, can you hear me?
Yeah, please, for the texture, is it that normally it's smooth, but in BPH is rough, or is the other way around?
So BPH is smooth, the normal one is smooth. So we said roughness, you see that in prostate cancer. So the DRE can tell us whether we are dealing with prostate cancer or BPH, because BPH is supposed to be smooth, even though there's an enlargement. But prostate cancer, you have nodules causing the edges to be rough.
Thank you.
Okay. So for the size, I was talking about the average size of the prostate. So the average size of the prostate is between 20 to 25 grams. So the average size of the prostate is 20 to 25 grams. So in DRE, the doctor says basically it's one finger, the index finger. That's what the doctor would insert into the rectum. So when you take a look at your index finger, you realize that there are 3 divisions. So from your finger, there's one division. Then from the first division, there's another one. And the last division is there. So you have 3 divisions on your index finger. Basically, these divisions are what we term finger breadth units. So each division is known as one finger breadth unit. So when you look at the index finger is divided into 3. And that means we have 3 finger breadth units. And for every 1 finger breadth unit, it's equivalent to 15 to 20 grams of prostatic tissue. So every 1 finger breadth unit is equivalent to 15 to 20 grams of the prostatic tissue. And what this means is that if the doctor inserts the finger and he tries to check the size of the prostate gland, and he realized that the circumference is covering 1 finger breadth unit. If it's covering 1 finger breadth unit, then that means the prostate gland is of normal size, because we said 1 finger breadth unit is 15 to 20 grams, and the average size of the prostate is 20 to 25 grams. So if it's 1 finger breadth unit, then it's essentially normal. However, if the doctor inserts the finger and he realizes that the circumference of the prostate is covering about 2 or 3 finger breadth units, then we can say the patient's prostate gland is enlarged, because 1 finger breadth unit is 15 to 20 grams. So for 2 finger breadth units, that is 30 to 40 grams. And 30 to 40 grams exceeds the average size, which is 20 to 25. So if you are getting 30 to 40, that means the prostate gland is enlarged. So that is how we are able to determine whether the prostate gland is enlarged from DRE. So we use the finger breadth unit. 1 is equivalent to 15 to 20. So 2 to 3 means it's enlarged. Are we clear on that?
Yes, please.
Okay. The other thing you can also check is the PSA levels. So the DRE tells you the prostate gland is enlarged, but it doesn't confirm prostate cancer can also enlarge the prostate gland. So DRE is just to give you an idea of whether the prostate gland is enlarged or not. However, you can also do the PSA levels. And the PSA, we said, is prostate-specific antigen. This, we said, is produced by the prostate gland, the prostate-specific antigen, PSA. These PSA levels are elevated when you have any inflammation or any enlargement to the prostate gland. So it can be elevated when you have prostatitis. So when you have infection of the prostate causing inflammation, it can cause PSA levels to go up. So prostatitis can elevate PSA. BPH can also elevate the PSA levels. The prostate cancer can also elevate the PSA levels. So you realize that what the PSA is not specific for BPH, because prostatitis can elevate the BPH and the PSA. BPH can also elevate the PSA. Then prostate cancer as all these things about. When the doctor inserts the finger and palpates the prostate, because of the mere palpation of the prostate gland with the aid of the finger, the PSA levels can also be elevated. So you can have elevation in the PSA level because of that palpation that occurred. So the rule of thumb is, for people you are suspecting have BPH and you want to do PSA levels, you should always take the sample for the PSA before you do the DRE. Because if you do the DRE first and later come and take the sample for PSA levels, it may be falsely elevated, because during DRE, you are able to palpate the prostate gland. And that can cause elevation in PSA levels. So the rule of thumb, take sample for the PSA or doing DRE. And even aside DRE, when there is coitus and there is ejaculation after coitus also increases PSA levels. So one of the precautions they usually take is that before you do PSA levels, you should abstain from sex for 24 to 48 hours. So 24 to 48 hours before PSA levels. If you abstain, we know that whatever value you are getting is a true reflection. But if you just had sex, then it will be falsely elevated, because ejaculation also increases PSA levels. So for the PSA levels, the normal is 0 to 4 nanogram per mil. The normal range is 0 to 4 nanogram per mil. That's the normal range. So sometimes people say slight elevation, they think about prostatitis. Moderate elevation, they think about BPH. And very high or marked elevation, they think about prostate cancer. But you can't use PSA levels to diagnose, and PSA levels alone to diagnose BPH. You need to do other investigation to confirm. And usually the confirmatory test is doing ultrasound. So you can do abdominopelvic ultrasound. So abdominopelvic ultrasound to check whether there are any complications, and there are also any to also confirm the BPH as well. So when you do the ultrasound, the ultrasound will give you an idea of the size, so whether it's enlarged or not. It will also give you an idea of the nature of the cell, where there's the enlargement. We said BPH, the enlargement is in the transition zone. So you have an idea of where the enlargement is occurring. And the nature of the cells there, are they benign do you have any cancerous tissue, is able to look for all the nodules and all that. So that's how we diagnose with the ultrasound. But aside the ultrasound, the PSA, the DRE, there are routine labs you always do. Full blood count, you can do your full blood count. Renal function is very, very important because BPH can lead to AKI. So it can lead to post-renal AKI as a complication. So you also want to do the renal function test. You also want to check the electrolytes. You can also have derangement in the electrolytes. So these are routine labs you can do. And you can also do urinalysis. So urinalysis, you check for the presence of leukocytes, the nitrites, and all that in urine. If you check and it's negative, then you know that you've ruled out UTI. Because the signs and symptoms of BPH can mimic UTI, urinary frequency, urinary urgency, and all that. You see that in UTI. So if you do urine dipstick, urinalysis, it rules out UTI. Then you know that you can concentrate on the BPH. Any questions? Okay. So that'll be that for the diagnosis. The next thing we'll be talking about is management. But we'll do that hopefully the next time we meet. We'll do the management and we'll also do questions on BPH. Any questions before we end? All right. So if there are no questions, we'll end here. Have a good evening.
Thank you, Dr. Isha.